So we ran this symposium in Zurich. It's mainly academic, so this is going to be a bit more complex than most of the podcast series, and it's only on YouTube because you need the video as well. But I'm just introducing this series of 6 lectures, starting off with Ed Hagen, who is a biological anthropologist, renowned for his work in various fields, but especially on mental health. He's been one of the longest-standing anthropologists to be working on anything to do with mental health in kind of non-Western and hunter-gatherer populations. So it's a really excellent way to kick off this series of 6 lectures, all of which are kind of thinking about evolutionary psychiatry, but are giving a bit more kind of data, and it's, as I say, it's a bit more formal than most of the podcasts. But for those of you who like that, hopefully you'll enjoy it. And now I'll hand over to Ed.
So first, depression is caused by adversity. This has been known for at least 50 years, if not longer. This is a review of several studies conducted in the 1970s and 1980s, looking at the percentage of depression cases in Black versus non-cases in hash marks there that have at least one adverse event. And what you can see is that the depression cases, roughly 80% of them involve adversity, whereas for the non-cases, adversity is not completely absent, but it's at much, much lower levels, maybe 20 to 30%. Another study, more recent, in twins, a population-based study, concludes that life events increase the risk of major depressive episodes. Yet another study, also in twins, men on the left, women on the right. Here, looking at a dose-response relationship between adversity and the hazard ratio for major depression. So looking at adversity from no adversity to low levels of adversity to high levels of adversity, you can see that there's an extremely sharp increase in the risk of a major depressive episode in a dose-response type relationship. And you can also see here it does interact with things like personality. Those colored lines represent different levels of neuroticism, with folks that have high levels of neuroticism being at much higher risk of having a depressive episode if they experience adversity. And also some interaction with sex, with women on the right there having a somewhat elevated risk of depression given similar levels of adversity or neuroticism. Okay, so what kind of adversity are we talking about? Real adversity, things like assault, rape, muggings, divorce, major financial problems, housing problems, illness or injury, getting fired from your job, legal troubles with the police, serious marital problems, getting robbed, having difficulties at work, or maybe most prominently death or illness of a close social partner. All of these were things that have occurred to all of us at some point in our lives, and regularly affected our ancestors and very plausibly had a substantial impact on biological fitness. So focusing in on one of these, divorce, here's yet another study. This is a register study in Finland where they have highly detailed data on a very large sample of the Finnish population, I think 10 or 11% in this particular study. So on the right here, and what they looked at are prescriptions of antidepressants as a proxy for depression versus prescriptions for other medications. So in our diagram here on the left column, we have men, on the right column, women. And in the top row, the sort of solid black horizontal line there that shows, looks like a mountain peak there, those are prescriptions of antidepressants among individuals who will have a divorce at that vertical solid line. This is a 10-year period we're looking at here from left to right. And the dotted lines in that top row are antidepressant prescriptions for individuals who are either not married or will not be getting a divorce. And that vertical black line is the time period when the people who will get a divorce are getting a divorce. And what you can see is among those individuals who will get a divorce, antidepressant prescriptions peak dramatically, just prior to the divorce and then taper off for both men and women, suggesting a very close temporal association between this proxy of depression and this recent adversity, i.e. a divorce. And so this is a really remarkable study because these time points, they look at prescriptions every 3 months, unlike those previous studies I showed you where there might be maybe 2 time points or 3 time points. Here we have time points every 3 months for 10 years. And you can see there's no peak for individuals who are not getting a divorce. If we look at the second row and third row, these are prescriptions of other medications in the second row, anti-anxiety medications in the bottom row, other psychotropic medications. And you can see there's either a very small peak for anxiety or no peak for the other medications. Again, suggesting a really close association, temporal association of depression with recent adversity. Now, let's look at the symptoms of depression. We'll see they're very typical responses to adversity that almost all of us have experienced or will experience at some point in our lives. So this is a recent study by Freed looking at 7 different depression instruments and the kinds of symptoms they assess. So that figure on the left, each concentric circle is one of the 7 depression instruments. Each dot is a particular symptom included in that instrument. Many of the instruments have overlapping symptoms. And what I just want to point out on the right here, if we look at the symptoms, these are very common experiences for all of us. Things like insomnia, anxiety, irritability, changes in appetite, grief, changes in weight, concentration, feelings of guilt, pessimism, loss of interest, loss of pleasure, fatigue, energy loss, gastrointestinal problems, crying, feeling, talking less. All of these things are the kinds of things that any one of us might have experienced if we had experienced a divorce or other kinds of adversity. And this is very much unlike schizophrenia and autism and bipolar, where many of the symptoms are extremely unusual and odd, and most of us wouldn't experience those kinds of symptoms. Again, suggesting depression is really different from these other very clear mental illnesses. Now, turning to the criteria that were developed in the DSM specifically for major depression, it's quite interesting that these were not developed to distinguish folks suffering a mental illness from either people just suffering ordinary sadness and grief or feeling completely healthy. Instead, they were developed to distinguish different categories of psychiatric syndromes from each other among folks who already were suffering a very severe psychiatric disturbance. So here are the 5 major studies that inform the DSM-3 criteria, which are very close to almost those used in almost all research today, very similar to the ICD criteria as well. As you can see, here are those very common symptoms like appetite loss, guilt, slow thinking, and so forth and so on. And if you look at each of these studies, what we'll see is that they only involve individuals who were suffering an illness, and they did not involve healthy individuals. They did not involve individuals who were solely experiencing sadness or grief. So Stone and Burris was a clinical study of 50 selected psychiatric cases. Cassidy et al. Was a quantitative study of 100 manic depressive patients compared to 50 medically sick controls. Feiner et al. Was a study of 314 psychiatric emergency room patients and 87 psychiatric inpatients. And Spitzer et al. With the RDC study, 218 psychiatric inpatients. So you can see that these criteria were just simply incapable of distinguishing folks who were genuinely mentally ill from those who were healthy, because it didn't include any healthy participants. None of these studies include any healthy participants whatsoever. Okay, turning on to the epidemiology of depression, we also see it does not resemble those of other mental disorders. So when these criteria, this DSM-3 criteria were applied to a community sample, i.e. where most people are healthy and very few are having a brain disorder, it generated huge rates of apparent disorder. So in that top line, these are some of the early studies in the 80s and 90s here. And you can see a quarter of the US population is being identified as having a brain disorder. And that is just simply unbelievable and incredible, and implausible, I should say. And if we look at major depressive specifically, anywhere between 5 and 10% of the population is suffering that supposed brain disorder. Again, just highly implausible. If we look at anxiety, 7 to 15% of the population suffering an apparent brain disorder. Again, just incredibly implausible. And that's because these criteria really weren't developed to distinguish in community samples as opposed to psychiatric samples, the relatively few folks suffering a genuine brain disorder from the vast majority who are not. And we see the same results globally. This is from the Global Burden of Disease study. On the left here, comparing rates of depression in the general population with rates of autism, bipolar, and schizophrenia. Those bottom lines there, purple, blue, and green, are rates of schizophrenia, bipolar, and autism. That red line are rates of depression by age. And you can see that depression just onsets very, very rapidly in adolescence. And that is very, very high throughout the lifespan compared to these other disorders, just order of magnitude higher. On the right, we see other kinds of brain disorders that onset late in life, neurological disorders, dementias, Parkinson's disease, very, very low in young adults in contrast to depression, and then spiking to much higher rates after the age of 60, but again, still far below the rates we see for depression. So again, depression is extremely common. Brain disorders are quite rare, genuine brain disorders. Again, unlike schizophrenia, autism, or bipolar, which are lifelong conditions that appear early in life, as Adam mentioned, most depression cases remit in about 1 year. So this is a large nationally representative study of a nationally representative sample, looking at how many, if we start look at the onset of depression, then how long do these, how many of these remit over the time periods of 10 months, 20 months, 30 months, 40 months. And what you can see is at time 0, of course, we're at 100%, but then it falls off very, very quickly. So when we get to about 1 year, right about here, about 75% of the cases have remitted. So this is very much unlike the patterns we see in schizophrenia, autism, or bipolar. Another large nationally representative sample found that most sufferers of major depression will have one lifetime episode, again, unlike these other very genuine brain disorders. So a recent study based on a large nationally representative sample found that among individuals in remission from major depression at baseline, the cumulative recurrence rate was 13.4% at 10 years and 27% at 20 years. Thus, at 20 years, the vast majority of people have not had another major depressive episode. And these very high rates of depression, as well as anxiety among young adults, generate very high disease burden scores. And that's because these scores are weighted by the degree of disability caused by the disorder. And I don't want to suggest that depression is not disabling. It really is. But they're also weighted by age. Things that occur early in life are weighted much more heavily than things that occur late in life. And so these are the breakdowns of the dailies that Adam showed you at the beginning here, broken down by age and broken down by mental disorders. And each of those colored lines being a different type of disorder. And what you can see here is depression is just really swamping all of those others at onsets, again, in late childhood, early, or not onsets, excuse me, but we begin to see cases of it in late childhood or early adolescence, and it just spikes hugely in young adults. And again, these are the weights that are weighting these cases much more heavily than the cases that we see later in life. And so these burden scores are used to establish research priorities. And I'm going to come back to that at the end of the talk. But the fact that depression, as well as anxiety here, that's this red line, are so high in young adulthood, this is really distorting research priorities for mental health research. Okay, we see this is the global data presented in a somewhat different way than Adam showed you at the beginning. Each of these rectangles represents the entirety of disease burden, infectious diseases, chronic diseases, non-infectious diseases like cancer. So each rectangle here represents the entirety of disease burden for these different categories of disorders broken down by low, middle, and high income countries. The red block there is the disease burden from mental health conditions. And what I've outlined in black there are the fraction of mental disease burden due to depression and anxiety disorders. And you can see in each of those squares, it's about half. So about half of mental health disease burden is attributed to depression and anxiety. Okay, so this is a problem because depression is caused by adversity. Its symptoms are very normal, ordinary responses to adversity. And so it's very troubling that there are such high rates of supposed brain disorders. And this is recognized very, very early. And that's why I use the word pretend in my title. Psychiatric experts have recognized this problem from the day one that DSM criteria were applied to community samples. So here's Robert Spitzer, who is the chair of the DSM-3 task force, considered to be kind of the father of modern psychiatric research, in a paper with Jerome Wakefield about 20 years ago, noting that the high lifetime and current prevalence rate for mental disorders in community based on DSM-3 criteria in the epidemiological catchment area studies and the National Comorbidity Survey raised concern that these criteria are overly inclusive. In other words, the concern was that the criteria resulted in many false positives. And by false positives, here he means identifying cases of brain disorders that are not genuinely disorders. He calls this the false positive problem. So in the case of depression, what did he suggest psychiatry should do about it? Well, he suggested that the definition of depression should be expanded to include the criteria that the disturbance, here's on the right, is just to be markedly excessive in intensity or duration relative to the nature of the stressor. And of course, this is the very similar to the bereavement exclusion that has been in DSM for a while and then eliminated, and I think might be back in now. But he's saying this should be really expanded. And if we did this, we might be identifying genuine cases of depression that are disorders, those that really don't seem to be an environmental response. That has never happened. Here's the chair of the DSM-4, Alan Francis, making a very similar point in a book-long argument here called Saving Normal: An Insider's Revolt Against Out-of-Control Psychiatric Diagnosis, DSM-5, Big Pharma, and the Medicalization of Ordinary Life. And here's the vice chair of DSM-5, Daryl Riker, making the same point. Again, this is an old paper based on the high prevalence rates identified in both the ECA and NCS, National Comorbidity Study. It is reasonable to hypothesize that some syndromes in the community represent transient homeostatic responses to internal or external stimuli that do not represent true psychopathologic disorders. That many of these are appropriate homeostatic responses that are neither pathologic nor in need of treatment. So this problem has been recognized for decades, and yet nothing has been done about it. Here is another book long, and so I'm far from the first, and Kristen Simon and I, you'll hear from Kristen shortly. She and I have been working on this for many years now, but we are far from the first to make this argument. Here is Alan Horowitz and Jerome Wakefield making the same argument: loss of sadness, how psychiatry transformed normal sorrow into depressive disorder. And notice who writes the foreword to the book here, Robert Spitzer. Okay, what can evolution do to give us some insights? There are many things that evolution might offer us when thinking about depression. I'm going to just highlight a few points here. Adverse events, such as losing a mate, losing status, death of loved ones, and physical assaults, these were regularly experienced by most of our ancestors and likely had substantial impacts on fitness. It is therefore highly unlikely that our brains would regularly dysfunction during these common adverse events. These are the kinds of situations when it would be disastrous to have a genuine brain disorder. You need all of your cognitive facilities firing on all cylinders here to deal with these adequately. So when should we see dysfunctions? Well, they should be caused by mutations, developmental disruptions, pathogens, toxins, physical injuries. And that's exactly what we see for things like schizophrenia here on the left and autism here on the right. There are now very, very large studies of the associations of genetic variants with schizophrenia. Schizophrenia is highly heritable, and that's because it is likely largely caused by deleterious mutations. So this chart is just showing the odds ratio of being diagnosed with schizophrenia with rare mutations on the left there on that bottom chart, or common mutations on the right. You can see that rare mutations, which are very rare, but they can have a huge impact, odds ratios of 5 to up to 100 if you have one of those rare mutations. Or if you have certain common variants, it increases your risk a little bit, but there's a lot of them. Those are those small blue dots on the lower right-hand side. Turning over to autism on the right here, very similar stories, rare mutations having a big impact on autism as well as common variants, suggesting that these developmental disorders are probably largely due to mutations. So Kristen and I categorized different psychiatric syndromes here by their prevalence in the population along the x-axis and their heritability score on the y-axis. Neurological disorders like Alzheimer's and Parkinson's on the right column there, psychiatric disorders like schizophrenia, bipolar, autism, and depression and anxiety on the right there. And in the top row, conditions that onset before the age of 60 typically, and in the bottom row, those that onset after the age of 60 typically. And what you can see here is that schizophrenia, bipolar, autism have very low prevalence, but have very high heritability, again suggesting these are developmental or genetic disorders. And if you look at depression, on the other hand, very low heritability, anxiety disorders, very low heritability, suggesting that these are largely environmental responses to environmental conditions, not due to genetic mutations. So they have very low heritability, and yet they have very, very high prevalence, about an order of magnitude higher than these other conditions. Okay, we are far from the first to make this argument. Randy Nesse on the left here, Adam noted his book earlier. The title says it all, Good Reasons for Bad Feelings. On the right, just a couple suggestions from several other researchers about what the functions of depression might be, how it might actually help us deal with adversity. Psychological pain hypothesis by Thornhill and Thornhill in '89, suggesting that psychological pain has very analogous functions to physical pain. Tubity and Cosmides in 1990, suggesting that depression might recalibrate our strategies for dealing with the world. What we've been doing hasn't been working. We need to change things up. Andrews and Thompson really focusing in on rumination, a key symptom of depression as an adaptation to solve the kinds of complex social problems that we might be dealing with. What I want to highlight is some of the stuff that Kristen and I have been working on, which is the profound role of anger and conflict in depression, and that this might be what really distinguishes depression from ordinary sadness and grief. And what you can see here is just several titles of just a few of the many, many articles that have begun to recognize the central role of anger and conflict in depression. And so anger, the unrecognized emotion in emotional disorders, trait anger and anger attacks in relation to depressive and anxiety disorders, levels of anger severity in psychiatric patients, subjective anger and overt aggression in psychiatric outpatients. This is really very well established, but I think very under-recognized. Now, what's the significance of this close association of conflict with depression? And Kristen will, I think, expand on some of this in her talk. But conflict is a central theme in evolutionary biology. It's almost everything we do in behavioral ecology. When we think about animal behavior and human behavior, at some point begins to involve conflict, sometimes in contrast to cooperation, sometimes it involves aggression. And I'm going to just highlight a couple of the implications I think we have here. So on the right, I just have a Venn diagram. That blue circle represents adversity in general. And there are many responses to adversity, things like sadness, grief, rumination, anger, maybe other kinds of responses. And only a subset of those really lead to depression. So most depression does involve adversity, but most adversity doesn't necessarily involve depression. And this is one of the big mysteries of depression. And what we argue is that victims of adversity often need costly help from social partners. And if you get it, you will probably only experience sadness or grief or maybe rumination or anger. But if you don't get it, because social partners can be reluctant to provide that costly help, that's when we argue you will become depressed. And the reason is costly signaling. And I think Kristen will go into this in more detail. But we're arguing that some of these mysterious aspects of depression, like prolonged loss of interest and suicidality, are actually costly signals of need. And just a few pieces of evidence that we have put forward for this: physical formidability, which would allow you to deal with conflicts of interest and resolve them in your favor, is a protective against depression if you're physically formidable. We also have another paper showing that when you do get depressed, or
sorry, this is your 5-minute warning, yeah? Okay.
Yeah, we're on the last couple slides, so thanks. Depressive and suicidality increase other people's beliefs that you're telling the truth and their willingness to help you. So how can we reduce the real burden of depression? To reduce the burden of infectious disease, medicine reduced exposure to pathogens by sanitation, for example, increased immunity, vaccines. It did not suppress immune responses. In analogy, to reduce depression, we must reduce exposure to adversity and increase abilities to resolve conflicts, not suppress adaptive emotional responses like depression with drugs or other means. However, medicine cannot reduce the likelihood of divorce, financial problems, or death of loved ones, nor can it resolve social problems. These are not medical problems. And therefore, conceptualizing depression as an illness warps medical research priorities. So these are the number of cumulative dollars spent by NIH on research in mental health from 2008 to 2022. And you can see that depression far exceeds research dollars than any of these other psychiatric syndromes: schizophrenia, autism, bipolar. $7 billion have been spent on depression, and that's money that is not going to investigate these other genuine medical disorders that medicine actually has a chance of solving. So to conclude, the high burden of depression diverts millions to billions of mental health research dollars to an imprudent effort to suppress normal emotions that are evolved to protect us from present and future adversity and social conflict. Instead, research should focus on reducing exposure to adversity and improving social networks so that when adversity does strike, which it will strike all of us, there are few conflicts and sadness and grief do not become depression. Thank you very much.
Thank you so much, Ed. We have time for a couple of quick questions. There's actually one in the chat. I think we'll just take the first one of those. When are we going to diagnose clinical depression and anxiety using physical markers rather than psychological ones? I think I know what your answer to that is going to be.
And let me see. So, again, I'm rejecting the whole idea that we can diagnose depression. And let me just make a few comments on that. So all the biomarkers, if you look at the studies of like brain scans and other biomarkers, most of them are imaging studies these days, fMRI and PET. And you look at the participants in those studies, they are depression cases versus healthy controls, quote, but there's a huge confound here because all of the depression cases, or most of them, as I've showed you, are suffering recent adversity and are also feeling sad. Whereas none of the quote-unquote healthy controls or very few of them are feeling ordinary sadness or grief because those have been excluded from the study, nor have they experienced recent adversity or much lower levels. So when we look at the imaging differences between the depressed and the non-depressed, there's a huge confound. We're looking at brain differences due to exposure to recent adversity and also to feeling ordinary sadness or grief. So when we look at those brain differences, what do they do to? There's probably many, many cognitive responses to adversity. There's probably many brain changes relative to ordinary sadness and grief. We just have no way of claiming that those differences in the imaging studies are specific to any of the mysterious symptoms of depression. So I kind of reject the premise of the question there and suggest that these imaging studies are highly misleading in what they can tell us. And the same, by the way, goes for these genetic results. There is some heritability in depression. There are some interesting genetic markers here. But there are many pathways from genes to outcomes. For example, divorce is heritable. So the heritability of depression could be the heritability of getting a divorce, which then leads to depression.